All right, so we finished up with general anatomy of the heart. Muscles, chordae, tendonae, septum, pectinate muscle, papillary muscles, the different chambers, okay, external surfaces of the heart, external vessels of the heart, right? Aorta, and then we talked about the circumflex artery, the interventricular artery. So now what we're doing is we're moving on to the conducting system. And when we talk about conducting, we're talking about electricity here. Okay, the conducting system. So heartbeat, a single contraction of the heart. Let me say that one more time. The heartbeat is a single contraction of the heart. First in the atria, then in the ventricles. And I've told you guys that before, right? Squeeze, contract. Squeeze, contract. So the entire heart contracts in a series. Okay, the sound that you hear is actually not the contraction, it's the valves. Okay, it's not the contraction, it's the valves when they're opening and closing. Okay, so cardiac physiology, two types of cardiac cell muscles, conducting and contractile. So one of them's going to contract and the other one's actually just going to send a signal. Okay, cardiac cycle begins with action potential at the SA node. Now that's important to know because we drew the heart. Okay? And right here is the SA node. It starts right there. Transmitted through the conducting system, produces action potentials in the cardiac muscle cells, contractile. Electrocardiogram, ECG or EKG, just depends on what country you're in. Okay, literally, that's all it depends on. Electrical events in the cardiac cycle can be recorded on electrocardiogram. Electrical events can be recorded. And we do that. We hook patients up to EKGs all the time. And it tells us what's going on with the heart. Now, smaller EKGs just give us a general rhythm, okay? Gives us a general rhythm and how fast it's happening. Bigger EKGs, like 12-lead EKGs, they actually give us every view of the heart. Okay? And when I say every view, I'm talking about 12 views of the heart. So an EKG. Now the conducting system, a system of specialized cardiac muscle cells, initiates and distributes electrical impulses that stimulate contraction. Okay? The cardiac muscle cells contract automatically. They contract automatically. Now, what we're talking about here, this whole entire thing that we're talking about is a conducting system, which means it's electrical, which means if there's no electrical current whatsoever, you're dead. Now, I say that because I'm going to go ahead and I know that you guys are going to hate me for this. I know those people that watch those television shows, you know, House and ER and all those other shows. You know, what do they do? What do they do? Do you guys remember this? Any of this? Okay? Oh, we don't have any electrical, so shock them. Right? And then like shock him or her or it. You can't. Dead is dead. If there's no electrical signal, you're not shocking them. Okay? A defibrillator works off of electrical signal, not off of the absence of electrical signal. Okay? So asystole, you're dead. You're gone. You have to have electrical signal for it to work. There has to be something there. So shocking someone when it's a flat line doesn't work. There's nothing there. So every time you see that on the television, they shock them. Yeah. They're dead. So the next time you're in the theater and you see that, and everybody's like, oh no, Lassie, come back. And they go to shock the dog, just yell, no, you can't do that in the theater. Because you can't. No signal's no signal. If there's no signal in the heart, there's no signal. Okay? Most of the time when people get shocked, it's because of arrhythmias. Crazy, erratic signals. And what we do is we shock it to reset it. We're not actually giving them new electrical current, we're actually resetting the heart. So we're actually stopping this conduction system so it'll reset. Now because it's automatic, guess what happens? Zap! boom, 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 boom. It starts over again. But if there's nothing there, we won't shock them. Now, it doesn't mean that we won't do compressions, we just won't shock them. Okay, so every time you see that on the television, boo and hiss at it because it's wrong. There has to be some type of electrical signal there. Okay? So structures of the conducting system, the sinoatrial node, the wall of the right atrium. The wall of the right atrium. So here you go, right up here. All right? So it says the atrioventricular node. It's a junction between the atria and the ventricles. So we're right down here. AV node. Node. Okay? So, conducting cells throughout the entire myocardium, which means we're going to send that signal all the way across the myocardium. Conducting cells interconnect SA and AB nodes, distribute stimulus throughout the myocardium. Okay? In the atria, it's called the internodal pathway. Okay? So, literally, that's what it looks like. Now it is sending it from the SA to the AB. SA node's actually called the pacemaker. Okay, it's actually called the pacemaker. And it says in the ventricles we have the AB bundle and the bundle branches. The AB bundle and the bundle branches. So literally, right here's the bundle and then the branches. Okay? And it conducts at certain rates. So this will actually conduct a signal at roughly 75 beats per minute. That's what it's setting it at. Okay? This, if this wasn't working, this will actually set the signal, unbelievably, at 50 beats per minute. So yes, it has the ability to set a signal at 50 beats per minute. Okay? If this isn't working, then this right here, the bundle and bundle branches, has the ability to set the beat at 30 beats per minute. Now, can you live off of 30? No. No, not at all. In fact, 50 would be a little tough too, but you could live off of it. All right? And it says pre-potential, also called a pacemaker potential. Well, that's the SA node. Okay, resting potential of conducting cells. Now it says it gradually depolarizes towards threshold. SA node depolarizes first, establishing the heart rate. That's why it's called the pacemaker, because it's actually setting the pace. Okay, and it's no surprise that we have what? External pacemakers. And there you go. Notice the bundle branches. So we come off, then we have the bundle branches, and then these guys down below here are called Purkinje fibers. Purkinje fibers, and they wrap around like this. Okay? They wrap around the bottom of the heart because what are they going to do? Send that signal all the way around the bottom of the heart, and what's going to happen? Contract. Okay? The ventricles are going to contract. So there you go. You need to know this conducting system. The way this conducting system is actually set up, we can look at an EKG and say, oh, this is working or this isn't working. Okay, we can actually tell you exactly what's going on in the heart just by looking at the electrical signals. Okay, so this is showing you the threshold and the potential. Okay, it is drawn out. The SA node will establish the heart rate. I don't know why they do 72. Every book from here to Timbuktu is 75. Okay? But they need to be different, so there you go. 72 beats per minute. It's actually 75, bless you. But, and it's actually lowered. It's slowed down from 100. Can anybody tell me the cranial nerve that innervates it and slows it down from 100? Vagus. Yeah. The vagus nerve innervates the heart and slows it down from 100 beats per minute to 75 beats per minute. Okay? Now, it says that the heart rate, the SA node, generates 80 to 100 action potentials per minute. Parasympathetic stimulation slows the heart rate down. Okay? AV node generates right around 40 to 60 And then the Purkinje fibers can actually generate 30. And then there's a recall note. The vagus nerve is the regulating force of the parasympathetic system that slows the heart from 100 beats to 75. All right? The vagus nerve. Cranial nerve number 10. So here you go. SA node in the posterior wall contains pacemaker cells. Connect to the AV node by internodal pathway. There's what we're looking at. Begins atrial activation. Step 1. Atrial activation. Now remember, it's a split second behind. Okay, so the electrical current begins and then your contractions. So it's a split second behind. So there you go. SA node activity and atrial activation begins. Oh, and notice they're giving you a little time thing. Time 0. Because remember, we have to actually time how many beats per minute, right? So that's what this is doing. Atrioventricular node in the floor of the right atrium receives the impulse from the SA node. Step 2, delays the impulse. That delay is called fill time. It literally is called fill time. F-I-L-L, not P-H-I-L-L. Okay? So it's actually called fill time. So it gives a little bit of a gap there, a little bit of time. Receives the impulse from the SA node, delays the impulse, atrial contraction begins. So because we're delaying it, we give it time to fill, right? And then atrial contraction begins. Now, remember, this is a split second. It's not like this. Electrical current, okay, wait a minute. Okay, go ahead and beat. No, it's more like this, electrical beat. Literally, that's it. It's so fast, it's ridiculous. Okay? Because how many beats per minute does a normal heart beat? 75. How many seconds are in a minute? Okay, so we're putting 75 in 60. Now do the math. It's craziness. If you were beating 60 beats per minute, okay, that's 1 second. That's 1 second. 1001, 1002, 1003, 1004, 1005. Why do you think they do that when they're doing compressions? A 1 and 2 and 3 and 4 and 5. So you keep that rhythm, you count it out. Okay? So literally when I say this occurs, it's literally this. Electrical beat. That's it. So there we go. We start spreading across. Notice it's on both sides. It's on both sides. It's not just on one side. You're not contracting just one atria. You're contracting both of them. Stimulus spreads across the atrial surface, reaches the AV node. Look at the 50 milliseconds. Pretty fast. Okay, you thinking about it? It's already happened. It's done. Craziness. Okay, there's our 100. There is a 100 millisecond delay at the AV node. Atrial contraction begins. Got that little bit of fill time. We're going to contract. What percentage of blood is being contracted from the atria to the ventricles? 80% is being contracted? 80% is being contracted. Someone want to correct that statement? What percentage is being contracted from the atria to the ventricles? Well, let's do 100%. If you take 80 away from it, what's left over? 20. Okay, where's your guys' worksheets? Pull your worksheets out. Number 8. Number 8 on your worksheets. What does it say? Here, I'll read it, just because. It says, blank percentage of ventricular capacity comes from contraction of the atria. Blank percentage. 20% of ventricular capacity comes from the contraction of the atria. How is the other 80% getting down there? Gravity. You guys remember that whole gravity thing I said? That gravity, 80% falls from the atria to the ventricles? So 20% is being contracted at this point right here. 20%. So 80% passively moves from the atria to the ventricles. 80% passively moves. And there's your answer to that one, 20%. The answer to that question is 20%. So, whoa, slow down, slow down. AV bundle in the septum carries impulses to the left and right bundle branches, which conduct to the Purkinje fibers, step 4, and to the moderator bands, you guys saw those in the muscle diagram, which conducts to the papillary muscles. All right? To the papillary muscles. So, Humpty, what do the papillary muscles connect to? Beautiful. Awesome. Yeah, the chordae tendineae, the heartstrings. Okay? Yeah. The heartstrings. It connects to the heartstrings. So when it contracts, when the ventricles contract, so do the papillary muscles. And because they're contracting, they pull down on the chordae tendineae to prevent the valves from flipping backwards. So there's the conduction down the septum, okay, to the Purkinje fibers, and those Purkinje fibers are going to start the contraction in the ventricles. Purkinje fibers distribute impulses throughout the ventricles. Atrial contraction is complete. Ventricular contraction begins. So as the atria contract, that signal's moving down into the Purkinje fibers, prepping for the next contraction. And there you go. Purkinje fibers. Okay, abnormal pacemaker function, bradycardia, okay, tachycardia. So tach is fast, brady's slow. Ectopic pacemaker, abnormal cells generate a high rate of action potentials, bypass the conducting system, disrupt the ventricular contractions. Okay? So, if we have any type of arrhythmias, any problems with the heart, it could be a number of things. We have to figure out what's happening. So when they say bradycardia, that just means that this whole heart is beating slow. If they say tachycardia, that means the whole heart's beating fast. If they say arrhythmias, that means the whole heart could be doing this, spazzing out. Okay, fibrillation, V-tach. Okay, so any of those terms, and I'm going to show you guys an example of this. Okay, I'm going to show you actually several examples of this. And this is what EKG techs learn. Okay, they learn this when they're in their program. Emergency department technicians learn this. They learn how to read these, how to understand these different pacemaker functions, abnormal pacemaker functions. So the electrocardiogram is doing just that. It's actually hooking nodes to you, electrodes to you, and it's actually telling where the heart has a problem if it has one. Now this says obtained by electrodes at specific body locations. Well, to start off, if we're just transporting you in an ambulance, we're going to do this. Here, here, and here. That's simple. It's a simple 3-lead. And it gives us a nice little triangle of the heart. Tells us what's going on. Pretty simple. It's not going to tell us a lot about it. It's just going to tell us the speed and maybe if something's really crazy. When we get to the hospital, it's a different story. Because then it's here, here, both your legs. Okay, so you got arms and legs, and then here, 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 all the way around the heart. Okay? Now there's only 10 electrodes being put on the patient, but it gives us 12 views, and so it's called a 12-lead. It gives us 12 different views of the heart. And what they're looking at is this SA to AV to bundle branches and Purkinje fibers. It's looking at this from every single direction. And that's how we can tell if there's a problem with the heart and its conducting system. Questions? That's about how quiet it is when I deliver this to EDT techs and EKG techs. They're like, whoa. Okay, and then it's about another 3 weeks of learning how to place, troubleshoot, understand, read. 3 weeks. What's that? Do I do? This school, I'm not sure has it, but Bellevue had it, so I taught it there. Okay, so yeah, I do teach electrocardiogram. I teach how to hook it up, how to troubleshoot it, how to understand it. Okay, and so this is abnormal patterns can be diagnosed via 12 lead. 3 lead, probably not. 5 lead, maybe. Okay, if you're on an ambulance with paramedics, you're going to be on a 5 lead. They're going to bring you in with that. If you're just being transported, it's probably 3 lead. Okay, and if you've ever been to the hospital, guess what they do? 1, 2, 3, oxygen, and a pulse ox. They put it on your finger, and you're like, right? It doesn't matter if there's anything wrong with you or not, they hook you up, because they need to read everything. Okay, so features of an ECG. P wave, QRS complex, and T wave. So this, my little eager learners, let's just take this and erase it for right now, because I can always do it again. Watch this craziness, and let's see who in the classroom lights up like a light bulb. You guys ready for this? Here we go. What does that look like? Do you guys remember this? Right? Action potential? You guys remember an action potential? Yeah. Of course, we have to have threshold. Okay, this is D. This is re. This is everybody's like hyper. Yeah. So this looks familiar. So that right there, that craziness you see right there, is actually 2 of those. And let me show you. It's 2 of them. The first one's the atria, the second one's the ventricles. Okay? So what they're saying is that by looking at this, we can tell you any part of the heart and if it's damaged. So let's go ahead and redo this. And let's add what they did. Okay? And there you go. So, P wave, atrial depolarization. See the little bump it's sitting on? That's atrial depolarization. Now that's pretty deep. This is pretty deep right here. Probably doesn't need to be that deep. I think maybe like that would be good. Okay? And then there's Q, R, S, and then T way over there. Okay, so P is atrial depolarization. Depolarization. Okay, so there's the electrical current for the atrial contraction. Then the QRS complex is ventricular depolarization. And then all the way over by itself is the T wave, which is ventricular repolarization, because it has to repolarize, right? Remember action potentials? When we learned about action potentials, it has to depolarize, or I mean repolarize. So by looking at that, we can actually tell you if there's something wrong with the heart. We can actually tell you if there's something wrong with the heart just by looking at this right here. Okay? So let me give you a couple examples of this. Where do we have a time? Perfect. How about this? What's missing there? P. That means the atria are not contracting. Not at all. Okay? What about this? What's missing? T. Yeah, that means the ventricular repolarization isn't occurring or is damaged. Okay? And so we actually spend time looking at these rhythms saying, oh, well, there's a problem right there. Or maybe too high or too low, or maybe too far apart. If they're too far apart, it's Brady. If they're too close together, it's tachy. And this is what we're looking at when we look at an ECG. Questions? Now that I've intrigued you guys, you're like, huh? Really? Yeah, I know. It's crazy to think about. So, P, QRS complex, and T-wave. You need to know them. So, if you've drawn it out on your stuff, you're good to go. Question, right up front.
You said on the second part that there's the ventricles doesn't repolarize?
Uh-huh.
But what about the second part?
Okay, so this is just, so here's your repolarization right here. A lot of times what will happen is there'll be a huge delay between the next one, which means it's actually what we would call skipping a beat. There'd be a huge delay. I just don't have enough room to draw it up there, but literally you would see a heartbeat, no repolarization, long blank, and then the heartbeat again. Go ahead.
So, does that, you can feel that on your pulse, right?
Mm-hmm. Yeah, pulse and heartbeat are directly linked to each other. Okay, so when we do this, how many beats per minute? There you go. You're taking someone's pulse or heart rate, beats per minute. Any other questions? I know it's better, instead of just doing this as a biologist and saying, this is the physiology of the heart, it's actually good to give you some examples, because then you can relate to it. And everybody's been to the hospital for one reason or another, whether it's a family member or yourself. Maybe you slipped and fell and you had to get stitches or something like that. But you know the machines that they hook you up to, the monitor machines. Okay, so time intervals, well, the PR interval and the QT interval. This tells us a lot about the actual heartbeat itself. So we have these intervals that tell us a lot about it. There's a 12 lead hooked up to a patient. Okay? Now, I always like this because I'm glad that they showed it on a gentleman and not a female, obviously, you know, for classroom purposes. We wouldn't want to have a breast hanging out there, but honestly, let me just tell you this right now, okay? When I first started working in the hospital, way back when, okay, this was what, '03, okay, so 2003 when I started working in the hospital and on an ambulance, I was like, oh my gosh, I saw parts. Their parts. After a while, I became so numb to it. You know why? Because I've seen every single type of part that you could imagine. Now, I say it like that, and I use humor, because we try to stay a little bit humorous about this whole thing. But you know what? I've seen every type of breast, every type of penis, every type of vagina. I've seen it all. So when I'm in the hospital, I'm literally blank faced. There's nothing I have not seen. And I mean it. I've seen it all. I know all the techniques to work with patients, especially women that have huge, huge breasts. Really? I mean, this is the kind of thing where they tell you, first off, you can't use your hand. None of this. Okay? So you have to use the back of your hand to lift their breast. If their breasts are so heavy that you can't do it, it's like putting your shoulder in it, trying to get the thing up there. Okay? If they're so big, they're hanging all the way down to their belly button. What are you doing? You're trying to, yeah, so literally you will say this, can you lift it up for me? And they're like, okay. Toss it over the shoulder, and you put the 12 lead on, and you go from there. But I have literally seen every shape and size. I've dealt with every ethnic, religious group you could possibly think of. Are you okay? Well, we know what's going to happen when she gets in the hospital. Phil says to just toss it over your shoulder. Okay? And interestingly enough, there are certain groups where, yes, I can help them, but they'll do most of the work themselves. Other groups, they'll just lay there. Like, I'll walk in and they'll be, just go for it. It's weird at first. The first time you ever see that, yeah. And they won't help. If they're huge and they just lay there, they're not going to help you. So literally, you're putting your shoulder into it. You're like, really? And you've got to hold this thing up like this and put these on. You're counting ribs. Hopefully they're not ticklish because, and you've lost it again. You got to start over. Okay? So, if you look at the placement on this patient, and they stopped doing this, they stopped using the nipple as a landmark. Okay? On a man, you could probably get by, but on a female, can you get by with that? Like, think about it logically. No, you cannot. You cannot use it as a landmark. So the landmarks now are literally counting ribs. Okay? Mid-clavicular, drops down, and there's your placement. You can count the ribs. You can actually count the placement of the ribs. And this may sound callous, but in the hospital, I'd rather hear them say, ouch, than anything else. Because if I'm poking their ribs that hard, that means I'm not doing what? Something inappropriate. Okay? So you'd rather hear an ouch or a grimace than something else, because you don't ever want it to come to that. So in the hospital, and like I mentioned in 241, so the people that are new to me, it's all the same. It's all the same. It doesn't matter. We're all the same. We have all the same bits and bobs, obviously male and female, but it's all the same. It's just a few different shapes here and there. That's it. Breasts are breasts, vaginas are vaginas, penises are penises. That's it, all the way across the board. So when you get in the hospital after a while, you're just kind of like numb to it. Numb. I mean literally numb to the whole thing. Because the patients have to be completely nude when you're doing all the work on them. Drawing blood, putting an EKG on, putting a catheter in. Really? That's getting up close and personal when you're putting a catheter in someone. Okay? So yeah, I'm glad that they use this. It's a good way to see how they placed it. Notice they placed it on his stomach. The placement of the first two leads, right here and here, and then they just wrap around the heart. So it gives us 12 different views, okay, of the heart. There's your image up above. That's standard. And then we take a look at it, and this is how we can actually count. We can count heartbeats. Okay? On the EKG paper, we can actually see the little squares. So many of these squares, 1,800 of these squares actually equals a time frame. Okay? Do you count every single one of them? No, because the machine will do it for you. And there's a math problem that you do for this, but you guys won't need to learn it. Okay? So this is showing you a few abnormal premature atrial contraction, AFib. Look at this noise right here, AFib. Now these are horrible examples. I'm going to show you guys some real-time examples. Okay? Showing you the, notice the P and T waves. Look at this right here as opposed to these. Look at ventricular tachycardia right here. Okay, and because all of these have electrical currents in them, we can shock them all. It's when there's an absence of electrical current that we can't shock. Contractile cells, well, Purkinje fibers distribute the stimulus to the contractile cells, which make up most of the muscle cells in the heart. Resting potential, well, about -70. Atrial cells, about -80. So it's a little bit different than what we're used to with our -70. You guys remember -70? Yeah. And then notice there's an absolute refractory period in there. What does absolute refractory period mean? Yeah, you cannot have another contraction in that time period. And it's drawn out, it's long. See the plateau causes CA entry duration. Okay, ends with the closure of slow calcium channels. So it's a drawn out, it ensures that one beat, no more, that's it. Now, can that be disrupted? Yeah, chemicals can disrupt it. Okay, electrical signals can disrupt it. So, time, action potential. Notice our cardiac muscle and contraction tension. So basically they're just saying that action potentials and twitch contractions in a skeletal muscle above, the cardiac muscle below, the shaded areas indicate the duration of the absolute and relative refractory periods. Now, you guys remember what relative is, right? If there's a strong enough stimulus, we can have another contraction. Absolute refractory period is long. Relative refractory period is short. Notice the recall note. Define refractory periods. What do they mean? What do refractory periods mean? Timing of refractory periods, length of cardiac action potential in the ventricular cells. 30 times longer than skeletal muscle. 30 times longer. Long refractory period prevents summation. Prevents summation. And remember what we talked about, summation. Okay? Is one graded potential enough? No. So if we had 3 graded potentials all at the same time, it's summation, right? Okay, that's what they're saying. It prevents that from occurring. Now, role of calcium ions in cardiac contraction, well, is produced by an increase in calcium ion concentration around the myofibrils. An increase. 20% of the calcium ions required for a contraction. Now it says arrival of extracellular calcium triggers the release of calcium ions, reverses from sarcoplasmic reticulum. So we're talking about just like a muscle contraction, except for the difference is it is drawn out. It's a long, long muscle contraction. It's not like the short muscle contractions we learned about. Okay, so this is just a refresher of what's happening. And then energy for cardiac contractions. Well, aerobic energy for heart. Well, mitochondrial breakdown of fatty acids and glucose, oxygen from circulating hemoglobin, cardiac muscles store oxygen in myoglobin. So, we just had blood, and we're going to stop on this note because I think we've gone far enough. I think we have. We're going to stop on this note. What is it called? What is the globin called in blood? Hemoglobin. Okay, and now we have myoglobin. Myo means muscle, so we're talking about the stored oxygen in the heart. The heart actually stores its own oxygen as needed. Okay? Now, cardiac cycle, a period between the start of one heartbeat and the beginning of the next, includes contraction and relaxation. So, we looked at this, we talked about this. Okay, systole. Diastole. Okay? Let's just change the names. There you go. So, 120 over 80 is what? Is the blood pressure. What are the terms used? 120 is the systolic. 80 is the diastolic. So, literally what you're saying is 120 is the contraction, 80 is the relaxation. And that's what they mean. Okay? So we'll stop right there. 5 to 7 minutes, and then we have a lab. A darn good lab.
Should we make copies?
Yes, you should make copies. Okay? If you haven't already made them, so on page 4, let me just make sure.
The one that we were working on?
Yeah, so you're gonna continue on with the one you were working on, so 454, 455, 456 of the review sheet, and where is my, there it is. So page 449, you can just reference that in the book. 449 is your dissection for today. We're dissecting the heart. What will you need to complete? You'll need to complete, so everybody already started 453 and 454, right?
Yes.
Okay, so now what you're doing is the rest of 454, 455, and 456, which is the dissection. Not today. You keep it as a, so we're going from 453 to 456. There you go. And quick, because we got a big lab we have to do.